Welcome to the Ending the Stigma Mental Health Panel. We're NAMI on Campus, which is an affiliate of the National Alliance on Mental Illness. We're basically just focused around reducing the stigma surrounding mental health and providing resources to students, both for on and off campus. Basically, this event tonight is just kind of our attempt at
having an event.
Well, more so
spreading awareness on campus for mental illness, and just letting, like, instead of just having an event where we have factoids, having actual speakers who have experience can tell you, hey, this is something I've dealt with. Maybe this is something you're dealing with, and maybe this is how you can cope with it.
Yeah.
And you can ask me questions and be like, what is more specific things I can do?
Yeah.
And so we'll have a Q&A jar.
Oh.
Mason. Oh, wait, just kidding. JK. Okay, that's not yet.
But wait, where? Well, they will be around. So we have these mason jars that are going to be like, we'll have two people floating around with them. Our wonderful Danielle is over there with one of them. And we'll be passing around paper as well. But just write any questions that you might have for any of our panelists. They come from a bunch of different backgrounds, so just...
And I'm Jana, by the way. We're in Devonport's 230 class, is it? I'm supposed to sign something. I don't remember what. But if you're part of that, let me know, and I will sign it.
Okay, doing good. Yeah, so Brogan.
That's good. Another thing about the Q&A jar is if questions come up, pass them outwards, and then we'll have Jana, or you're clicking, right?
Yeah.
Jana and Danielle will collect them on the sides. And I'm Brogan Glover-Smith. I'm a junior here at Western. I am on the Board of Education for NAMI on Campus. And I think that's all I have for you. Yeah. Should we get started?
Yeah.
All right.
That you can bounce back even when your back is against the wall? Do you believe that you can rise from the ruins? Believe you can. Believe you can. Believe. I always like to start off with a little spoken word poetry to infuse the place. So first I want you to raise your hand if you think you know somebody who's diagnosed with high blood pressure, heart disease, asthma, or any sort of physical illness. Raise your hands high. Okay, you can put your hands down. Okay. Now I want you to raise your hands if you think you know somebody who is diagnosed with a mental illness. Raise your hands. Okay, you can put your hands down. So I speak across the country. And when I ask this question, I get different responses. What do you think the responses are? Why do you think they're different? What do you think the responses are? Right? For the first one, people shoot their hands straight up. Yeah, of course I know somebody who has heart disease and physical illness, right? When I ask the second question, people's hands raise up very hesitantly. And it's like, why didn't you raise your hand straight up? One is a physical illness, the other is a mental illness. I believe that they did not raise their hands straight up because stigma. That hesitation is stigma in action. And because of stigma, we well know right here in this room, people are losing their lives, people are losing jobs, people are losing housing. This must change.
Alrighty. So thank you for being here today, too. Thank you to the panel. And I'll just go down the line and introduce you, and then they'll go into further detail. So we have Koss on the very left. We have Joanna, Jose, Sarah, and Anne-Marie. So we'll start with Koss on your introduction.
I'm getting a motion for, can you please pass the microphone down?
Got it. And I got it. Perfect. And my role here is to really think about the suicide prevention plan for Western. And so is there developing this campus-wide plan for suicide prevention, looking at things like academic supports for students, campaigns related to things like stigma, and then also looking at policy and greater issues like lethal means restriction.
And I am, so you want introductions and then present? Okay. So I'm Joanna Glover, and I'm the mom of 3 people, and I will talk about that in more depth. And I have 2 sons who live with mental illness, and I'm a NAMI educator. Because of that, I get to teach families in crisis about mental illness. And I am a crisis intervention specialist for Edmonds School District, so I get to help children who are in mental health crisis. And I'm also a speech therapist at the school district. And I have 2 dogs, so busy life.
Hi, I'm Jose. I am a philosophy and behavioral neuroscience double major. I'm also the president of the Nerds Club, the Neuroscience Club. I think I see 1 or 2 of you in here. I wanted to join this panel because I've experienced mental illness myself, as well as a lot of my family. And one big part of the stigma that I see is that people see it as this thing that's in your head or sort of not real. And so coming from a neuroscience background really helped me solidify that these things are very real and can be explained in very scientific mechanisms, although we may not understand all of them.
Hi, I'm Sarah. I'm a freshman here at Western, and I'm actually a secretary with NAMI on campus. I have personal experience living with mental illness and living with family members who also battle mental illness, and my goal is to help educate and share my experience with everyone else who is interested in learning and wants to know more about mental illness, and to encourage them to reach out for help.
Hi, my name's Anne Marie Tyler. I'm a licensed mental health counselor, and I work in the counseling center up on 5th floor, Old Main. I've been there. I've been working in college counseling for over 23 years now, and have kind of also transitioned into some administrative responsibilities. So I'm the assistant director of our clinical services. I have had the great privilege of working with students for, as I said, over 23 years, and one of the gifts I think I've been given in terms of working at the counseling center is I'm able to provide support and some treatment to people without having to work too rigidly inside a diagnosis box. So it makes me keenly aware of how we all experience symptoms that people with mental illness struggle with, but we're all on a continuum with them, and so we have a lot more in common than we have a lot different. And I'm really honored to be asked to be here today.
All right, so now we'll start with Jose.
So I didn't really prepare anything, so I'm just going to talk. So I got interested in behavioral neuroscience because I saw it was a program here, and I was like, I've never heard of that before. What is it? And I took 220 a few years ago, my freshman year, with Dr. Carroll. And one of the first things he said that class, he was like, about statistically 25 to 50% of you have a mutation in a serotonin gene, all of you that are sitting in this class, that makes you more susceptible to anxiety. And there's nothing you can do about it. Like, you have this, like, you can't get rid of it, you can't change your genes. That's not to say you're going to have anxiety, but it just means you're more susceptible. Kind of the point of this was these things in your body that you don't necessarily think about, like genetics or maybe chemical balances, are very much connected to your personal experience and your mind, because as far as we know, everything tells us that your brain is the place of your mind. And so the illness that I've experienced is generalized anxiety disorder. I kind of realized growing up, even at the age of 5, 6, since I can remember, I would excessively worry about things that are maybe unrealistic, overthink a lot of stuff. It's not all the time. I go through phases of it. It can be maybe like a day or sometimes a week or maybe like a few hours. I'm also a very creative person, and so that it makes it easy for me to create new worries and about things. And you know, sometimes it's with school, sometimes it's relationships with other people, or uncertainties about the future, or something like that. I did not know that this was a disease or a mental illness until I kind of started learning more about neuroscience, because I come from Peru. I'm an immigrant from Peru. I came here when I was 7, and the stigma against mental illness is really, really big in Latinx communities. I've had brought it up to my parents before, like, like I can't stop worrying about this. They would just be like, well, just stop worrying. It's all in your head. Once you stop worrying, it'll be fine. And it was, I can, they weren't trying to do me any harm or anything, but to express these things to someone who is, who, loves you so much, and have them tell you, like, this isn't real, can be pretty hurtful. Also, I've had a lot of family members. I have an uncle who's bipolar. My mom has generalized anxiety. My grandmother was never diagnosed, but she probably did too. And I have other family members with addiction issues, as well as depression. And so it makes me wonder how many of these people in my family have been kind of invalidated by others in their community by just being said, this is all in your head. And so what does this mean? It's all in your head. It can mean two things. I guess it can mean you're making this up, this isn't real, or literally it's in your head, as in this is happening in your brain. People mean the first one, that this isn't real, because you wouldn't say to someone who has heart disease, oh, this is all in your heart. It's like, what would that even mean? Like, yeah, obviously, like, it's there. And so I'm going to give you one example of how our mind interacts with our body and brain to produce, I guess, something that people would consider mental illness. And so we have a part of our brain, our amygdala, that gives us emotional response. And so way back in evolutionary history, one of our old ancestors would see a snake or something that is harmful, and it would initiate this sort of response in your amygdala, and then that would talk to your hypothalamus, then your pituitary gland, and finally send signals to your adrenal gland, which is on your kidney, that would release adrenaline and those kind of hormones into your body. And we all know what that feels like, like when you hear some bad news, or you get a bad grade on a test, or you're scared, your heart starts to pump a little bit, your skin warms, you might start shaking. That's those chemicals being released. Eventually, adrenaline goes back and kind of inhibits this cycle. So it starts in the brain, goes down to the adrenal gland, and then it'll inhibit it. Now that was thousands, millions of years ago where that system got put in place. But then we evolved something called the frontal cortex, which is, what we consider ourselves so special compared to other species. It allows us to think, allows us to importantly, it allows us to create scenarios, to imagine scenarios in our head. And so I don't have to necessarily have experienced what it's like to, as one author said, to eat onion and liver ice cream. I can, think about it and be like, yeah, that sounds pretty gross. We can kind of create these scenarios in our head without necessarily experiencing them. So we have this really great imaginative power that comes from our frontal cortex, but we still have this really old system of emotional response that's ingrained, that's in our brain. And so what happens is I don't necessarily have to experience bad news or experience something of that sort, but I can just think about it, and in that way it gets the emotional response going as if it were actually happening. As if I don't need to see a snake, I can imagine snakes, and that's a little simple example, but you get the point. And so in people who have anxiety disorders or PTSD, that system is kind of not good at regulating itself. So instead of experiencing some sort of fear and then initiating a fear response and then having the body shut it down, it just kind of keeps going and is not able to regulate itself. Because evolutionarily, this system is not in place for us to be constantly worried, right? It's just there to alert us of certain dangers so that we can stay alive, basically, and reproduce. But when the system is not working, which can be for a variety of reasons, some are outside of your brain, like can be something like hyperthyroidism or things having to do with your hormones. Others can be, you're deficient in certain chemicals, or certain parts of your brain have been damaged, or you've had a specific emotional experience or traumatic experience that kind of made it difficult for those inhibitory systems to start to do their job. And so you get this kind of constant response, and that's kind of what anxiety feels like. Sometimes it can feel like you're literally on adrenaline like the entire day, and it becomes difficult to eat. You're worried thinking about the same thing. There's a type of animals called ruminants, I think cows and buffaloes, and what they do is they chew food and they'll go down into their stomachs. It's pretty gross, and then they spit it back up and then chew it again. And so I've heard that word used for kind of to describe anxiety, because you have this worry, you think about it, and then you spit it back up and you think about it again. There's no new information, nothing has changed, and you can't really control it. Well, not at that moment, at least, And a lot of the time, there's no new information, and it's the same worry. You can't necessarily rationalize it, because a lot of the time I realize, this is really, this is stupid, this would never happen, this is really unrealistic, I know I'm overthinking it, but that rational part of my brain sometimes can't necessarily quiet down the other part that's giving me this emotional and physical and very real response. And so in terms of my journey with anxiety, something that has been shown to help almost all mental illness is exercise, just taking care of your body in general. And I know it sounds really lame to be telling you to exercise, but seriously, like cardio 3 days a week at least, it will, your brain is intimately connected to the rest of your body. So if you take care of one, the other one will start to get better. Personally, meditation has done wonders for me. I think everyone should start meditating, whether you have anxiety or not. Studies have shown that consistent meditation over long periods of time have actually changed areas of your brain, and you have more gray matter in your hippocampus, which is involved in regulating that emotional response I mentioned. And then if those things don't work for you, and there's always medication, as well as therapy, like cognitive behavioral therapy has been one to really work. You can find out all about these things and resources at the counseling center, which I'm sure will be brought up later as well. Really the best thing is a combination of these, and like I mentioned, whether you have a mental illness or not, exercising and meditating is only going to make your life better, and it doesn't take that much time. And so take care of your body, and hopefully your mind will follow. There has also been, I've noticed there's some stigma behind medication, like some people being like, pills aren't gonna help you deal with your problems, and sadness is more complex than that. It's like, yes, I'm not saying just take a pill and you'll be fine, but some people literally can't just talk to someone and feel better, because there's a chemical imbalance in their brain that requires medication to improve. And so telling someone it's not good to kind of push aside all medication. It's definitely not a cure-all, but some people definitely need it, and their lives would be not nearly as good without it. I think, how am I doing on time?
You're great.
Okay. What does that mean? Do I have time left?
Yeah. Sorry. Yeah, go for it.
Like I said, I'm president of the Neuroscience Club. Learning about the brain has really kind of solidified all these things for me, and also giving me, I guess, a venue into learning about myself, and as well as others and their behaviors. I want to go into medicine. I'm not sure if I will go into psychiatry or neurology yet. I don't quite know what I want to do, but it'll definitely be part of my practice to kind of bring these things up. And like someone else mentioned earlier, everyone's on a continuum. You don't necessarily have to be diagnosed with anxiety disorder to experience anxiety sometimes, and it's really good to learn how to deal with it. And I think it's something that everybody, all students, all people should know and should practice in their day-to-day lives.
So this is a little bit more of a personal story. So I have been diagnosed with generalized anxiety disorder, bipolar II disorder, and clinical depression. I received my diagnosis for anxiety and depression about 3 years ago, and eventually my diagnosis for bipolar disorder in June of this past year. My mom has battled anxiety and depression her whole life, so I had a pretty good understanding of my diagnosis when I received it. She and I have battled our diagnosis very differently, however. When I was in the 2nd grade, me, my mom, and my little brother lived in North Bend. We had already moved 3 separate times after my parents divorced when I was about 3, and at this time we were living with another new guy. The thing about this guy, though, was that he didn't treat my mom very well. I remember laying in bed at night, listening to them yell at each other and hearing furniture and things being knocked around. He abused her. She had bruises, bumps, cuts. This is after we moved very abruptly from Eastern Washington, after the guy we were living with at that time was charged for sexually molesting and raping his young children. My mom began to develop a substance use disorder, using alcohol and cigarettes as a crutch to escape and cope with everything going on in her life. I've had a few boyfriends over the years, some getting to know me and my mom better than others. It hurts to be broken up with because I lost interest and it's just not working out, but it hurts most when they call you crazy and they call your mother crazy. So I guess I won't be myself. I don't like myself. Nobody actually likes me. I'm a burden. Everyone would be better off without me. I was hesitant to reach out for help at first because going to therapy would only confirm everything my past boyfriend said to me, that I'm crazy, right? Therapy saved my life. What happens with bipolar disorder is you'll go through fairly long-lasting major depressive episodes. I spent a majority of fall quarter in one of these episodes. I frequently thought about killing myself, and one night I almost did. It was around 1:30 or 2 o'clock in the morning. My roommates were all asleep. I was about to take a shower and just broke down crying completely out of nowhere. My thoughts were racing, and my mind was cycling through thoughts of how I wasn't good enough and how much better people would be off without me at the most rapid pace. It was impossible to slow them down. They kept flooding faster and stronger. I opened the medicine cabinet, sobbing, and gazed at the top shelf, where I kept a plethora of prescription medications for sleep, muscle relaxation, panic attacks. I thought it wouldn't be a bad way to go. I'd just fall asleep and never wake up. I made a life or death decision then and called my campus's crisis line that my counselor had given me. A campus police officer was able to come to my dorm, talk to me about what was going on, and we mutually agreed that I would go to the hospital and admit myself into the ER. I was handcuffed and sat in the back of the police car, and I sat in that hospital for 4 hours. I did a lot of thinking in that 4 hours. I've also done a lot of thinking in the past 2 weeks. I had 2 very close friends pass away within 4 days of each other last week. One of them died from an accidental drug overdose, and I attended his funeral this past Saturday. Many of the eulogies encompass the importance of reaching out for help, and I want to reiterate how true this is. I would not be here today had I not reached out for help when I most needed it. Unfortunately, like my friend Matt, some of us have trouble reaching out for help, and sometimes that can be deadly. Death is not an escape from pain, and it does not end it. It passes pain on to other people. I've gone through a great deal in order to learn this, but I realize how lucky I am to be alive. I want to help other people, and even if I can help one person, that is a gift. I could not have made it to where I am today without building the support system I have now, and it is so important to reach out because there is a light at the end of the tunnel. Thank you.
Thank you, Sarah. Now we will have my mom. Joanna, sorry.
So I am a mother of 3. I'm a speech pathologist, a NAMI educator, and a crisis intervention trainer. We are a family of 5. My husband and I, my husband's here too, we have 2 sons, a 24 and a 23-year-old, and my daughter who is a junior here at Western. So 10 years ago, my oldest son developed schizophrenia, paranoid type, which was diagnosed at the age of 14. He had been symptomatic for probably about a year before we were able to get him diagnosed and treated through inpatient hospitalization. Because of stigma and lack of awareness, his teachers, extended family members, and even his psychiatrist at the time failed to see his psychotic symptoms as a serious mental illness. Although I fought for treatment, he was 13 years old and he had a legal right in the state of Washington to refuse treatment. It wasn't until he attacked me on the street in Seattle and was strapped to a gurney by police that he started to receive treatment at a hospital. He met the legal burden for involuntary commitment. He was now a danger to himself or others. The frontal lobe of people living with mental illness doesn't work well during the episode of the illness. Our frontal lobe helps us perceive illness and know that we need help. The law protecting people from involuntary hospitalization relies on the person's ability to perceive their own illness until they are extremely ill and potentially dangerous. Stigma and lack of awareness have supported these laws. At the time of his hospitalization, our insurance covered 11 days of inpatient treatment for psychiatric illness. My son was hospitalized for 4 months. This has changed, luckily. People have fought, and NAMI and a lot of people have fought. And now insurance companies are required to treat mental illness equivalent to physical illness. This is another organ of the body, it gets sick. And so change is possible with advocacy. My son now lives at home, he's med compliant, and he attends a 2-hour weekly social group for people living with mental illness. There are no other supports in the community for him. 2 hours a week, he goes to a group. Tax dollars do not support community services for mentally ill citizens. Recovery does happen, but the burden falls on the family. 4 years ago, my second son attended Western Washington, and he was in the fine arts program. He has a brilliant mind, and he developed bipolar disorder with psychotic symptoms. He was hospitalized 4 times in 2 years. While in inpatient treatment, patients are stabilized using sufficient dosages of psychotropic meds to balance the soup of neurotransmitters that render the patient psychotic, depressed, catatonic, and a host of tragic, debilitating symptoms. The acute treatment for our son was such a heavy dose of varied meds that they were not sustainable. He could not function with the cognitive and physical side effects of that dosage. Each time he was sent home with a prescription and a psychiatric appointment with his outside provider. One of those discharge plans included a psychiatric appointment that was 6 weeks out. Although we provided as much support as possible, he was unable to maintain his recovery. We are not psychiatric professionals. He was not med compliant, and he was hospitalized for progressively longer times, each of those 4 times, with progressively more severe symptoms and higher dosage of meds. Because of stigma and lack of awareness, outpatient treatment is often not sufficient to meet a patient's therapeutic needs. Private providers and insurance companies are not funded to support the level of service that is needed in the acute stages of recovery after inpatient treatment. So this is a metaphor, as Jose was saying. When somebody is discharged with such a lack of services from a psychiatric inpatient treatment, this is the equivalent of a cardiac surgery patient being sent home with the family with an open, gaping chest wound. The family is given meds that may not work, and they may have catastrophic side effects. The family is given some nice line, maybe a needle, to sew up the chest, and they're given a follow-up appointment with the cardiologist 2 to 6 weeks out. Thank you. So we refused the fourth time to take my son home. On that fourth hospitalization, we feared for his life. We weren't doing a good enough job. Things weren't getting better. And at that time, because we didn't want to take him home and experiment again with failure, he then received service from the Snohomish County PACT team. And that is a program of assertive community treatment. This treatment included immediate psychiatric appointments, as needed, a therapist who came to our home weekly, because traveling to those outside providers and getting in the car when the brain's not balanced, the anxiety level was so high that by the time we would drive him to appointments to see outside providers, he couldn't really access the service because his anxiety was so high. And so this team of professionals know that, and the therapist comes to the house, and the therapy happened in his man cave or up on the couch where he could really access the therapy. And he had a peer counselor who would come and take him out to Starbucks or whatever. And the peer counselor is a person who's living with mental illness and is successful in their own recovery. And so that was really good for him to see that he wasn't alone and that he was going to be able to have a life someday. So there were also many group support meetings, depending on the need of the person. There was addiction meetings, there was art therapy meetings, so lots of really wonderful support in the PACT program. And for 2 years, this intensive support, along with the structure of a healthy family home, have facilitated his recovery. There needs to be enough dollars that everybody leaving a hospital gets that level of service, that revolving door doesn't continue or people end up in prisons and tragedies don't happen. We need that level of service. Stigma blocks his path at this point to job reentry and socialization. He bravely fights every day to stay on his path. Stigma leaves us isolated and continuing to search for healthy support for our sons. And I know that someday brain illnesses will receive the attention that they require. I know that someday this organ will be treated like other organs in our body. And thank you for listening and choosing to increase your awareness, because in doing so, you're fighting stigma, and you guys you're the future that's going to change this for society.
So we're going to have Anne Marie start off.
All right. Just to reintroduce myself after you've gotten a bite to eat, my name's Anne Marie Tyler, and I'm a counselor in the Counseling Center. And I'm I'm going to share a little bit of information with you, as well as, kind of lead us into our question section of the presentation. Just in case I forget to tell you, for those of you that are students, I've got some brochures here from the Counseling Center. This just tells you a little bit about our services, and I also have a card that has some crisis resources too, so please feel free to help yourself. Want to give a shout out to Joanna and her family for having the courage to talk about their family and their family's experiences, and just their refusal to allow stigma to silence their family. And sharing your story I'm very touched by that. And also Jose and Sarah, for their courage in sitting up here and sharing their own personal struggles with mental illness. I know that's not an easy thing to do, and it just demonstrates incredible resilience and your value on advocating for support for people with mental illness. So I just got to ask, can you just give me a hand one more time? They deserve that. Yeah. So when we think about mental illness, I just thought it was interesting to also consider, what do we consider mental health when we're talking about mental illness? And this definition is from the Center for Disease Control. And part of their stance is that, you know, in addition to supporting appropriate treatment for mental illness, we're also charged with protecting mental health and mental wellness. And they came up with a definition of mental health, which you see up there. It's a state of well-being in which the individual realizes his or her own abilities, and that's recognizing our abilities realistically, right? Our strengths and our weaknesses, can cope with the normal stresses of life. There's no life that is stress-free, right? We all go through difficulty, but having that ability to cope with it, being able to work productively and fruitfully, and being able to make a contribution to their community. And it's interesting that they say it's estimated that only 17% of United States adults would be considered in a state of optimal mental health. Mental illness, all diagnosable mental health disorders, or I kind of like the second one better, that health conditions characterized by changes in thinking, mood, and behavior, and that they're associated with distress, and that they impact our functioning. And as I said earlier, for many of these issues, we're all on a continuum. When we hear people talking especially about struggles with mood or struggles with anxiety, we've all experienced anxious moods. We've all experienced depressed moods too, but we're on a continuum, and when it starts to go into that area of what we call mental illness, it starts to really interfere with functioning and causes higher levels of distress. So along with this theme of considering the difference between physical illnesses and mental illnesses, they're all seated in the body, though. We are all biological animals, right? So the brain is a part of the body. So differentiating physical illness and mental illness in some ways, you know, we're kind of creating a false category there. But if you think about somebody I've called Chris, that they are somebody that has a heart condition, and you think about, would you say to Chris, I don't believe in heart conditions, just get over yourself. Think positive thoughts, and it'll get better. Don't care, just do your job, I don't want to hear about it. Or telling Chris, get more sleep, just get something to eat, get more friends, get a grip, calm down, and stop your heart palpitations. You had a heart condition last week. Why are you still talking about it? And other people have it worse than you. My chest hurt once, and I just ignored it, and it got better. So, you know, would we say that to Chris? Probably not. And the interesting thing about a heart condition is that some of those things probably would be helpful with a heart condition, wouldn't they? Like, what would be helpful if you had a heart condition? Get more sleep, yeah. Eat healthy. Get more friends. Actually, getting more friends probably is going to help with heart health, because our sense of social community can improve our physical health. Even the thinking positive thoughts, you know, having a positive mental attitude can also help with a heart condition. But we're not going to think that's going to be the primary cause of treatment. So the question I asked here, which, you know, Hakeem in the video is also posing, is why is it that an illness in the brain elicits judgments about character that having depression, having bipolar disorder, having anxiety, it's a weakness of character. Denial, denying symptoms, denying talking to people about their symptoms, because you're sure not going to get treatment if we're denying that something's going on. Isolation for a person struggling with mental illness, and feelings of shame. In the students I talk to that are struggling, so often there's that feeling of shame about it, like I shouldn't be going through this. I should just be able to handle this. Not the same as Chris dealing with a heart condition. Does anybody have any theory about why it is that brain illnesses elicit that judgment? I really struggled thinking about it, and I don't know. Does anybody here? I mean, really, just to comment on it. Yeah.
This isn't really a theory, it's just a comment. I was a sociology major here at Western a little while back, and our test would always be, does it hold true across time and culture?
Yeah.
And I was wondering if you had anything to say about other cultures not viewing mental illness as such a bad thing, and maybe as more of a gift or creativity or things like that. What other cultures?
Yeah, that there might be other cultures that look at difference in terms of emotional functioning or even perceptions of the world, that they're not necessarily seen as mental illness. I think, sometimes it can really go both ways, and I think especially in first world industrial cultures, there's so much disengagement from each other and from people and from community. That can add to the isolation and the conditions that contribute to mental illness. Yeah. Hi. Stigma. Were you thinking of, why is it that mental health has stigma whereas other physical illnesses don't?
I think part of the reason is because as Americans, we're supposed to deal with everything on our own.
Yeah. I think that's...
If you have a mental illness, it's almost like there's something wrong with you as a person.
Yeah.
Not wrong with your brain, just wrong with you.
Yeah.
I've had that happen more than once on occasion.
Yeah.
Mostly from family members. Sometimes from classmates, sometimes from coworkers. And they all come up with pretty much the same theme. It's simply, why don't you get a job? Or why don't you get a girlfriend?
Yeah.
Like that's the magic cure.
Right.
And I think that's another something that is also, I think, part of the
I think that's an excellent point. It's, our culture really values individualism, and it's like this is an individual problem. Unlike, like you were saying, other cultures are a little bit more community-oriented and, more likely to focus on supporting each other. So, yeah.
Another anecdote that I'd like to share is that anytime a person in a church gets heart disease or a broken leg or something like that, anything that's physical, these people get food. I mean,
Yeah. Let's bring out the meals. Yeah.
A mentally ill person doesn't get anything.
Yeah.
You're a sinner,
Yeah.
or something to that effect.
Yeah, you just need to pray your way out of it, which is not to discount that, but we wouldn't say that to somebody dealing with a physical illness. The community is still going to rally. Yeah, I know I think we're ripe for questions, so I'll run through the rest of my slides real quickly, and I think we're getting there. So, all right. Just wanted to talk real briefly a little bit about mental illness. I know NAMI is a wonderful organization and they really support education. So just to talk a little bit about some of the major struggles people have when they're coping with mental illness. Depression includes feelings of sadness, hopelessness, of course a depressed mood, loss of interest in activities that used to be enjoyable or used to give you pleasure, often a decrease in sex drive, change in activity. Some people get really agitated when they're depressed, especially with teenagers. We seem to see a little bit more of that agitation and irritation. Other people find themselves just kind of slowing down when they're experiencing depression. Difficulty sleeping or sleeping too much. Feeling tired, not having energy, feelings of guilt or worthlessness, difficulties concentrating, and thoughts of death and suicide. As I said, we're all on a continuum for that, but when we're looking at what is considered an episode of major depression, so clinical depression, it means you're experiencing these symptoms for more than 2 weeks. When we look at anxiety disorders, as Jose talked about, excessive and unrealistic worry about everyday tasks or events, difficulty with concentration, sleep problems, irritability, restlessness, or just feeling on edge all the time, muscle tension, you see people with just chronic back pain or headaches, physical stress reactions, because when that fight or flight kind of adrenaline system is triggered all the time, digestion doesn't work as well. So we'll get people with, chronic digestive discomfort and problems. Phobias are a type of anxiety where your anxiousness is centered on maybe a certain object or certain situation, or on interacting with others, like social anxiety. And then some people with anxiety disorders get panic attacks, which are huge waves of adrenaline when your body just, it's flooded with adrenaline, heart is beating like crazy, difficulties breathing, huge muscle tension. People often think they're having a heart attack or that they're dying the first time they have a panic attack because it's so extreme. So those are all symptoms that we often see with anxiety disorders. Again, most of us have experienced episodes of anxiety, and I think it gives us empathy, but somebody with an anxiety disorder, it really kicks in there, and it's recurrent and difficult to control. And the generalized anxiety disorder, it's coping with those kind of symptoms for at least 6 months. Bipolar disorder, all of these things have a biological component. I think bipolar disorder in particular, we can really have a predisposition to that. And a lot of times with bipolar disorder, and of course with some of the psychotic disorders, we're usually, in terms of treatment, looking at a combination of medication and therapy. But with bipolar disorder, usually you have periods of that really deep major depression. It's for the students I've worked with manic depressive disorder, bipolar disorder, the way that Sarah was describing, it's pretty bad. It's pretty severe depression. And then for the bipolar, 2 poles, they also get episodes which are either manic or hypermanic is what we call them. So there's times when there's depression, and then times when people are really have much more energy, usually an elevated mood, but sometimes that can be an agitated mood. Increased energy, increased activity, sleeplessness, and an ability to get by with less sleep than normal, racing thoughts, pressured speech, an exaggerated sense of themselves and what they can do. There's sort of a lack of being able to really judge, hey, can you really do all those things in one time? Read a book, register for 25 credits, start your graduate school studies, and, also burn the candle at both ends by going out all the time. And also an increase in high-risk behaviors, because when people are in that elevated mood or manic mood, they have a hard time judging things. And, often we get a lot of substance abuse, can get excessive spending, excessive sexuality, so really revved up during those times. So that's bipolar disorder. And then with schizophrenia, again, really looking at, something going on organically in the brain. Problems with thinking or cognition, which psychologists like to come up with fancy terms for things, so we like to call thinking cognition. Problems with your behavior, your emotions, and a lot of times people with schizophrenia will experience delusions that are like false beliefs that aren't based in reality. Often with a delusion, we'll see some paranoia where people think that people are monitoring them or following them. Hallucinations, when you're imagining things that aren't there. People do sometimes have visual hallucinations or smell hallucinations, but most often people that are schizophrenic will hear voices. Disorganized thinking and speech. We notice in the counseling center, because people with schizophrenia really sometimes struggle with organizing their thoughts and tracking things. We generally, they have great difficulty functioning in school, and usually can't stay in school, have to really drop out of school and focus on treatment. You may see people who are with schizophrenia that are disorganized or show abnormal behavior. Sometimes they're agitated, might be inappropriate, might be bizarre. And then sometimes we see negative symptoms, which means there's things that are lacking. They're lacking the ability to just kind of function on a day-to-day basis, lacking self-care, like not having good hygiene, not really keeping track of eating and sleeping. Sometimes they show a lack of emotion, social withdrawal, and disengagement from everyday activities. And, my other slide here just notes that for men, schizophrenia symptoms often start in the mid-20s. Not always. You can, show symptoms younger, women somewhat later, but most of you are college students, and so this is kind of the time of life where we do see people with the first onset of schizophrenia, and also bipolar disorder tends to we see those first episodes in the 20s as well. Just to talk about a couple other disorders, there's anxiety compulsive disorder, which is anxiety where people have just recurrent and disturbing thoughts, which we call obsessions. And sometimes those are obsessive thoughts about illness or obsessive thoughts that I'm going to get contaminated or infected with something. Sometimes people will have obsessive thoughts about violence that it bugs them that they keep having these thoughts, but they can't get rid of them. They keep recurring again. And then you may or may not also have repetitive behaviors that somebody feels like they have to do. Classic of this for OCD is people that have to wash their hands all the time, and not just like a little germ phobic, but washing your hands to the point that your hands are just raw and red, and you just can't stop. Sometimes people get into pattern of checking behaviors, and I'm very forgetful. I will often go back and make sure I've locked my door a couple times in the morning just to make sure, did I really lock it? But somebody with OCD, they may end up spending an hour and a half in the morning checking things and rechecking things, and it never feels like you're done. There's also trauma and stress-related disorders that are when we go through a traumatic experience in life. Either you go through a trauma or you witness a trauma, and this is like a PTSD type thing. It can be a one-time event or it can be an ongoing trauma, like, for example, somebody who's experienced child abuse, or somebody that's been in the military that has experienced trauma over and over. And the symptoms of that are reliving or re-experiencing the trauma, feeling like you're back in that traumatic situation, a feeling like you need to avoid being around things that remind you of that traumatic experience, and then just we often see some depression with trauma reactions, or just that anxiety system is hypervigilant, so what we call anxious arousal. Eating disorders too, are other types of disorders, and substance abuse disorders. And I just have a note here, it's you're at that age where you are probably seeing friends transition from this sort of experimenting maybe with alcohol and drugs to more and more that alcohol or drugs becomes a central part of your life. And in terms of your day-to-day functioning, it becomes more and more important to think about, when am I going to drink? When do I get my first drink? When do I smoke that first bowl? Seeing this on some of your friends, I'm sure. And then, in terms of dual diagnosis, that's a term that we give when we are seeing people that are dealing both with some of those mental health disorders like depression, bipolar disorder, schizophrenia, and also having substance abuse problems. And we do see those two frequently occurring together. Few more slides. When we look at the prevalence of mental illness, in a given year, about 1 in 5 adults in the U.S. Experiences mental illness, and 1 in 25 is going to have a mental illness that really is serious and substantially interferes with their ability to function. 1 in 5 youth experiences a severe mental disorder at some point during their lives. A little over 1% of adults live with schizophrenia. Just a little under 3% live with bipolar disorder, and about 7% have had one major depressive episode in the past year. 18% of adults in the U.S. experienced an anxiety disorder. Could be generalized anxiety disorder, or PTSD, OCD. And of the people in the U.S. who experienced a substance use disorder, about 50% of them had a co-occurring mental health disorder, so those two really go hand in hand. As a counselor who's worked in the field for a number of years, I'm particularly concerned about with the legalization of marijuana, I see some casualness about using cannabis, and my concern is that for people that are already somewhat predisposed to mental illness and bipolar disorder and schizophrenia in particular, and we don't always see that first incidence right until the 20s, but for people that are predisposed to that, I think pot and cannabis can just be toxic for them because it can trigger a psychotic episode. So I encourage people to be really careful with their use and be really careful with friends for their use, because it's not a benign drug for some people. It's extremely toxic to their mental health. All right. I think we'll skip that one because that one's a little hard to read. So finally, what can we do about it? So, I think one thing, especially in terms of reducing stigma, is, to not collude with this not talking about mental illness or judging mental illness, and really to bring kindness and compassion to talking to others or talking about mental illness too. Really challenging attitudes that imply that mental illness is a character flaw or a weakness. Supporting early treatment, really some of the exciting research coming out, I think, about the brain indicates that there's a concept called neuroplasticity. The brain actually has this wonderful ability to kind of rewire neurons and sort of adapt. And one of the reasons that we do look at therapy and treatment and medication is to create new neuron pathways to compensate for some of those patterns. It's tough because the brain, we're biological animals, right? And the brain actually kind of has a negativity bias. Our brain is biased for being extra vigilant and looking for negative information because that's a survival response, right? So sometimes we have to compensate for that negativity bias in the brain by, kind of creating new ways of looking at the world. And for people with mental illness, this is often a process that we're working on in treatment. Helping friends and loved ones find the right level of support. Again, I've got brochures here for those of you that are students to know about our services, either for yourself or to recommend to a friend. When we look at treatment, you can get very much into a social justice direction, to think about, what early support is going to be better, right? When you look at mood disorders, for example, they're the third most common cause of hospitalization for people aged 18 to 44. If we can prevent hospitalization by having earlier treatment, it's going to be more cost effective anyways, if you have to use that language to rationalize it, and certainly more humane to people struggling with mental illness. And, the most heartbreaking loss we can have when we're not getting early treatment is suicide. And it's the second leading cause of death for people 15 to 24. One more little point about treatment, too, is that there's often barriers to treatment in multicultural communities, too. They often have less access to treatment, and therefore less likely to get treatment, lower rate of health insurance. Often there is higher levels of stigma with mental illness, poor quality of care. Often have to access health systems that are just culturally insensitive, that are not welcome, and you do see racism, bias, and homophobia in treatment settings too. So being able to provide equal access to treatment is really important, and because mental illness is not just an individual problem. It occurs in a community, and there's a cluster of resources that can help prevent more severe experiences with mental illness. So having access to basic needs, having access to fair housing, employment, education, healthcare, to help prevent conditions that just exacerbate mental illness and to avoid discrimination towards the mentally ill. If you've struggled with a mental illness, remember that you are not your mental illness. You are so much more than your diagnostic disorder, your mental illness. You may have a mental illness, you may struggle with symptoms of a mental illness, but you are much, much more than it. And the couple other things, is just to say, let's create a community that supports mental health. And finally, learn, ask, care. All right.
Doing Q&A, so I will grab one out of the jar, and then I can also we'll switch between that and then just wanting to raise your hand. So the first one I have is, When is the right time to turn to medication rather than therapy or counseling?
It's a really good question, and I would say there's not a set formula for anybody. I think, sometimes I think if you're particularly getting what we call vegetative signs, let's say, for example, for depression, and energy's really low, and your appetite is off, and you're having difficulties with sleeping, medication can be particularly helpful. Certainly, when people are having recurrent suicidal thoughts, we kind of want to bring in the big guns, so to speak, and maybe combine counseling or therapy with some medication just to kind of quiet things down a little bit. Because when you're feeling suicidal, you've reached a level of distress where most people who are feeling suicidal don't really want to end their lives. They really want to end their emotional pain. So we want to do what we can to alleviate that pain. Studies seem to indicate that medication, if you're looking between medication and therapy, they're both somewhat equally effective. But if we're looking long-term and wanting to prevent recurrence of a mental health issue, therapy can help with that reoccurrence. So, yeah.
And I would say that, as you said, as far as like an organic illness and
Yeah.
severity of illness, like for both of my sons,
Yeah.
without medication,
They wouldn't function.
They couldn't function at all.
Yeah.
And because their neurotransmitter system doesn't work
Mhm.
now without medication. So probably going to a professional to see what's needed.
Mm-hmm.
Certainly not a thing that we could know. for
Definitely,
ourselves.
yeah. When somebody is experiencing, especially bipolar, because of the risk of not treating the neurochemical part of it, I tend to think medication quicker. Certainly any kind of psychotic symptoms, to be able to function. Really OCD too, often really benefits by medication as well too. But, a lot of people with depression and anxiety have found medication helpful as well too. One thing I will say about medication is if you are taking medication, you got to look at the other side. You got to look at substance abuse too. If you're taking an antidepressant, alcohol can be a depressant. Pot can disrupt sleep too. So, if you're going to be taking medication, make some healthy choices there.
Okay. So the next question is, what can we do in order to eliminate the stigma behind mental illness?
Well, one thing that you're all doing is just educating yourselves first, because in order to reach out to anyone or educate others, you have to know. So thank you for being here again. There's not like a specific list of things you can do, but it's just try to incorporate it in your day-to-day life. Maybe share your experience with someone, or talk about it with your peers, or maybe family. It's like, hey, I went to this really cool presentation that NAMI made, and just bring up the topic because it's something that's avoided and not really talked about. And so seeing someone you're close to talk about it will maybe make that person, maybe they did want to talk about it and they just felt scared. So opening up to someone about that can also lead them to open up and kind of start this bigger change.
And I've written to and I've talked to the media because I get so frustrated when somebody who is imbalanced has a gun and a tragedy happens and the news say, what's the motive? There isn't a motive. There's a neurochemical imbalance. So why don't we just talk about that? What if the news, what if Como 4 talked about that? How awesome would that be? Because families like the Burlington shooter, that family tried to get help for a long time. Can we talk about it? Why do we continue to act ignorant? It just amazes me. So I think you guys talking about it. And when you hear the next shooting, look, read about the history of that family, read about what happened, and talk about it.
I think one other thing we can do is to stop using mental illnesses as, as adjectives in our daily lives. Like, I have heard people say, like, oh, you're so bipolar. Sorry, I'm so OCD when it comes to keeping a clean room. But I feel like it starts to dehumanize the mental illnesses, and it takes away from the people that are struggling with these illnesses, because they are real things. And yeah, that's one thing I think.
I think the biggest thing, stigma. What's that? Well, bottom line, the way I see it, it's like an 8-cylinder firing on 6 cylinders. That's number one. Number two, you look at a guy with a heart surgery. He's in the hospital. Somebody in a freaking wheelchair. Hello, the media, you guys. I mean, the age you guys are, this is the future out here, man. Make a difference. Make it, don't talk, do. Talk's cheap, not really. Do. That's Captain Kirk, by the way.
He pays for the cell phone, so he knows talk's not cheap.
Yeah, I had a comment and a question. My comment is that this is going off kind of what you were just saying.
Yeah.
Anyone in the red scarf? Sorry.
Oh, Sarah.
Sarah,
Yeah.
okay. Language is super important, and one thing that I have a mental illness, and as part of my journey, one thing that's been really helpful for me is to not identify as literally as my mental illness, but say like, I have this.
Yeah.
Like no one would say, I'm cancer.
Yeah.
Like why would you say I'm bipolar?
Yeah.
Because it just like kind of messed with my identity in my head, like, oh, I'm this. It's who I am. It's something I have. So like when you're using language, person first language is super important, I think. Like someone with bipolar disorder, someone with schizophrenia, things like that. So that's like, I try to throw that out there.
Yeah.
Anyways, my question. There's a lot going on politically right now in our country. We all know that. I think it's like a lot's happening on the national level, but I'm curious what you all think we could do on like a hyper-local level, like here in Bellingham, on campus. What are some things we can do to reduce stigma in our specific community, because it's really easy to get overwhelmed with everything that's happening on a national level. That's kind of the question, so.
I think we're entering, I think we're entering a new era of activism, and I have a hope about that too, that, with everything that's been going on, that we're moving that direction, that, regardless of how you feel about the political situation, I think, people are feeling more engagement, more involvement in caring and deciding, I need to do something, rather than just allow things to happen to me, So it's like you were saying, and you're Joanne's husband, aren't you? Yeah, that, we need to do something, trying to decide, how to act, rather, what to do in terms of action instead of just kind of talking about it, maybe, and worrying about it. So, it's. I love your question because it's a challenge.
Yeah, that's true.
Yeah.
Great question.
Yeah.
And the thing, not to get back to what I said, but I deal, imagine this, counselor, my wife, who is my teacher, very sharp. I deal with that with guys on the boat. I'm not, jumping in a car and getting rid of a situation. I got to deal. I had a guy last trip, that big smaller guy that, kind of flipped out, but it didn't alarm me. I saw the body language, and I dealt with it for 35 days. I called her for advice. Should I take him in? I'll buy the Russian border. This is like 2 weeks ago. And I've seen a guy almost jump overboard.
Yeah.
So I've seen a lot. It's not about, put them in an ambulance and going. It's not that easy. So I feel it's around me everywhere. So.
Okay, so I have another question. A friend and I both have bipolar disorder, and it can be hard for us to know what's the disorder and what's just us. Do you find it hard to differentiate between illnesses and normal fluctuations in mood?
Big sigh there.
So the difference between like the actual episodes and then just normal fluctuations. In my experience, I've kind of gone symptom by symptom, whether to help me identify whether or not I am entering an episode. Like if I feel maybe unusually happier than I have, or I do feel like I want to take on more than I normally would. Those are kind of things that kind of point me towards like, okay, maybe I'm like starting to enter like hypomania. I feel like I don't need to sleep as much and whatnot. And then on the other end of the spectrum, entering like a depressive episode, what kind of signals me off to that is maybe sleeping a lot more. I don't want to hang out with some of my friends. I start engaging in, might engage in like behaviors that that aren't necessarily healthy, that'll, I think might help me escape, but they aren't necessarily helpful. But that compared to normal fluctuations, you kind of start getting into a rhythm where you start being able to identify like what a normal mood is, and then separating that from, all right, I'm starting to enter this really extreme end of a spectrum or this really extreme end of a spectrum. So
add to that, I've never experienced what it's like to be bipolar, but from an anxiety point of view, sometimes it's really hard to know whether this is a real thing that I should be worried about or it's not. And one way I've dealt with it is to, like, I'll just talk to people I'm close to and who have, seen me go through this before. I'm like, hey, like, this person said this. Like, should I be worried about this? And they'll be like, no, like, or like, yeah, I would be worried too, like, and then we'll talk more about it. It's kind of, like I said, like, people are mentioning you are not your mental illness, but it's definitely part of who I am. It's definitely, in a sense, part of my personality. Like I mentioned, I studied neuroscience. I also studied philosophy. And what you do in philosophy is you pick one question or one issue and you look at it with a magnifying glass and you try to be so precise, and so you overthink. Basically, you overthink it. And that's how you're a good philosopher. You think about every single detail and every single way that your answer could be wrong or misinterpreted. And I think that's kind of what drew me to it, and it brings a lot of joy and a lot of meaning into my life. That's not to say I couldn't have found that if I didn't have anxiety, but it just kind of works. I have a friend who she has schizoaffective disorder and is bipolar as well, and she introduced me to this term neurodiverse as an alternative to mentally ill, because in a lot of ways, not to say it's good to have a mental illness, but some people's minds just work a little different, and that's not necessarily a bad thing, and it can enrich their lives in some ways.
Yes. I was kind of looking to utilize numbers that we've got here. But how do you kind of balance managing your own mental health with also helping family members? Because a lot of us are affected by our moms or dads, sisters, brothers having mental illness, but then there's also knowing when to step away and take care of yourself.
Absolutely. Well, I strongly believe that you have to take care of yourself, and it's never, you just can't feel guilty about that. Whatever you give yourself to take care of yourself, you have to do, including having boundaries, like a boundary that, yes, you have mental illness, but you still can't verbally abuse me. And so to have boundaries for the behavior that I can handle within the home. And then as far as like for myself, I think give yourself 2 hours. Like even a 2-hour vacation. So whatever it is, it's a movie or you just leave for 2 hours and you can leave. Even if somebody really needs you, go take care of yourself for 2 hours. That can be so rejuvenating. So whatever is super rejuvenating for you, I play guitar and I can go out to my little studio and play and come back and then I'm recharged. So I think all of us have, everybody, mental illness or not, we have something within us that recharges our batteries, and we've got to give that to ourselves. And it's never selfish, even if somebody needs us beyond anything in the whole world. When my husband and I used to come up and visit Zach in the hospital here, every other day we'd drive up when he was hospitalized for 3 weeks. We would go have a really nice lunch before him. And we'd laugh sometimes and think, God, we probably look really sick. Like we're having this lunch, we're laughing over lunch, we look like horrible parents. That's okay, because then we went to the hospital and we landed for him. But you've got to do things for yourself.
Really resonate with what you mentioned about finding like those things to help you recharge. Even as someone who's not taking care of someone else, there are certain things like I also play guitar, I play music, and it's been like the most helpful thing. If I'm thinking too much, I can just start playing guitar or drums and just kind of lose myself in it. And then by the end, you know, it's not like when I stopped I won't be anxious anymore, but I at least would have a break and my body has a break, and I can maybe then start feeling a little better. So those things that really resonates.
Okay, so the next question is directed towards cost, I would say. So this question is, what do I do when a friend or family member is expressing suicidal thoughts?
Yeah, and I will welcome also Anne Marie to step in as well in this. So first of all, thank the person for sharing. I mean, that's huge that somebody would feel so comfortable that you would notice those warning signs. Because one of the things I do is provide trainings on how to equip people. What are some warning signs, some things that we might notice in a friend or a loved one that makes us very concerned that they might be unsafe. And then reach out to that person, show compassion, let them know that you care about them, that you love them. Express language that shows that they're very, very important. And so that's kind of the intervention. I care about you. I've noticed that. And when I do my trainings, I often recommend that people use I language so that the other individual doesn't get really defensive. And so things like, I've noticed that you're hurting yourself, or I've noticed that you're disconnected to me, from me, or I've noticed that you haven't gone to class. And so that way, you're showing the things you've noticed, you're expressing that concern, and ideally they're not getting defensive. Offer support, offer to go with that person. I'm really worried about you. Can we go to the counseling center? Can we call a counselor? Can we call a hotline number? Because the stigma of mental health and suicide can be so strong that the last thing you want to do is make that person feel like they're even more isolated and more alone. So shifting in and making it a we thing. And then ideally getting that person to some kind of professional help. And if it's not in the kind of situation where you can walk them directly over to the counseling center, calling a national hotline number, texting, a crisis line, but something in that moment, getting that person some help. So those would be my recommendations for, and I don't know if Anne Marie, and I think also it's recognizing the boundary and your role in that situation, that you're not the professional, and that kind of turns back to that, what are my boundaries, what can I do in this situation? And in that situation, you're expressing that you're caring, that you're noticing these changes, and you're getting that person to professional help.
The only one little thing I would add to that too might be that sometimes when people express suicidal thoughts, they say, promise you won't tell anybody. And, just say, I can't promise that. I care about you, and having you here is the most important to me, and finding the right way to support you. So don't promise not to tell anybody, because if you're a good friend, you'll risk having them mad at you because you did tell somebody and really were insistent, especially with somebody that needs immediate support. You're like, no, you know, I'm going to fight for you, and I want you here, and, you know, we need to get you some help, so.
And there's another question while we're on this topic. It's, are there certain precursors to predict committing suicide? A general guideline to observe by peers.
Yeah, so maybe there are certainly some risk factors, and when we talk about risk factors associated with suicide, there are a lot, and I like to stress that just because we have risk factors for suicide, it doesn't mean that we will die by suicide. So things that might make you more likely to attempt or complete suicide would be things like a history of trauma, prior suicide attempts, certainly any kind of mental health, mental illness. About 90% of people who do attempt suicide have some kind of underlying mental illness. Trauma as a child, abuse, self-harm. So those are some risk factors that certainly will set us up for, or make us more likely to attempt suicide. And there are warning signs. And so some of those warning signs are serious. Things like not caring, distancing. Some of those are immediate, saying things like, I want to die, or it's not worth going on anymore. So yes, there are. And I would say the biggest risk factor of all for suicide would be that prior suicide attempt. So if you have somebody in your life who has attempted suicide, those individuals are much more at risk for attempting suicide again. So I hope that's answered that question.
Okay, so the next question is, how do I get help if I don't have insurance?
You know, if you're a student, you know, I would certainly come into the counseling center and talk to us about what's going on. Some of you that have heard about counseling center services probably hear us describe our counseling as more brief counseling, but you know, just because of the number of people coming in, and we do a fair amount of referral off campus for people that are looking for weekly treatment or counseling, but many people come to the counseling center just as a starting point, and you know, part of the reason we're there is to kind of, we want to ask about those barriers if you're looking for more regular treatment. And one of the areas where we've been putting a lot of energy is increasing our group counseling resources. And a lot of the students I talk to, when we talk about, you know, well, if you want weekly counseling support, we have a wonderful group for you. A lot of students are like, I don't know about a group. You know, I'd feel uncomfortable in a group. Once people get into one of our counseling center groups, you know, they have a very positive experience. And you know, it's the power of sharing your journey with other people that are also struggling and supporting each other can be very powerful. So I would say, you know, come in and talk to us. If you're like, you know, wanting to kind of figure out what are my resources for getting health insurance, hopefully no dramatic changes coming on that. In Washington State, you know, we do have some resources even in Whatcom County for helping navigate the Washington State healthcare system to AppleCare, and we have a case manager at the counseling center who can help direct you to some of those resources too. So.
I could just add something, just because I know a lot of what students get pretty freaked out by is just so like, okay, you'll refer me to a therapist, but then what if I don't like them? And I know that used to be one of my fears, but they usually hand you what, like 3 therapists in the area who there are therapists who do sliding scales, so like mine doesn't accept insurance, but she does it for $25 an hour, and she's a wonderful human being. So if you want me to hook you up, but
you got a recommendation.
Exactly. Yeah. But in general, you can also ask therapists about doing consultations. So they'll do like 30 minutes. A lot of them will do it for free or over the phone. And then you can just figure out like, does this actually work?
So you don't really have to commit to anything awkward. It's just reaching out.
I forgot too, there's also a program called, maybe you were referring to it, BHAP, Behavioral Health Assistant Program too, for people without resources. Gets them a few sessions too, for either free or for limited, reduced cost. And maybe, I'll interject too that, if you're looking at resources for medication, the health center actually is able to prescribe psychotropic medication. And you can get in much quicker to the health center if you're a student, but you can get in much quicker there than you can get off campus. So, the 6-week wait, that's, unfortunately, we're hearing that here too, or even longer, so. Off campus.
Yeah, just to add to the counseling center stuff, it's not a requirement for you to think you have some sort of mental illness to go there. It's a great place to go if you're kind of having like a mental crisis, like school's overwhelming or something happened to your family or even a relationship, and it's just kind of taking over at that moment. Even if you don't feel these things all the time, it's a great place to go. And it's completely free. I've been there a lot of times. They're really friendly. So yeah, it's a resource you have, and I mean you're paying for it and your fees and stuff. So use it.
Yeah, just super quickly going off of what Jose said. Just coming from a student, the counseling center is awesome. I go to a weekly group there, and it is so helpful. So I just wanted to chip in because it's awesome coming from a counselor who works there, but a student who goes there, it's awesome. And like as they were saying, it's included in your tuition, which means it's pretty much free. I mean, you're already paying for it, so why not utilize it?
Yeah.
Yeah. So the next one is, how do you recommend a friend or family member to seek counseling without insulting them due to the stigma?
I think for me, having gone to counseling before, I will open it up by bringing my own experience. And so by doing that, it kind of gets rid of this attitude of I'm a psychiatrist, I'm acting as a psychiatrist, but oh look, I was feeling this way, and using I language. I was feeling this way, and when I went to the counseling center, this is what I got out of it, and this is how that helped me. If that sounds like something that interests you, I can kind of help you get to that resource. So kind of instead of saying you should do this, being, hey, here's this option available that worked for me. I think that's a really non-aggressive way to go about it, and non-insulting as well, because you're saying, hey, look, I did it too.
Good suggestion.
It's also a benefit of you can only say that if you have gone to counseling, so it's another reason.
I like the way you think. Okay, so the next one is, where can I meet other students with mental illnesses?
NAMI!
There you go.
Just saying, we're here.
1 p.m.
Meet once a week. Be there. I'm there. Thank you.
I'm there too.
I like new friends.
And also, I guarantee you all already know people in your life, whether you realize it or not.
Yeah. I know as a family member, once I get to know somebody well enough that I'll open up about our family situation, invariably there's somebody in that group who also has a family member who lives with mental illness. It's just a lot of people are quietly living with this situation, so a lot of folks do.
I know that the Counseling Center and NAMI Whatcom offer support groups for anyone dealing with different types of mental illnesses or anything kind of related to that, so you can also check those out as well.
We also have some coping skills workshops which are open to anybody, and the reason people come to coping skills workshops is they're probably dealing with some anxiousness or difficulties with mood, and they're looking for some strategies, including mindfulness.
Are those free?
Those are free. And they're drop-in, you don't have to sign up or anything, and they're at the health center at 4 o'clock on Mondays, and in the counseling center at 10 o'clock on Thursdays. And we also have a drop-in yoga class too, which is on Fridays in the Viking Union. Yeah.
Okay, we have one last question before we end here, and this is, how do I go about helping a friend who has a mental health issue but chooses to refuse help?
There's a great book by a man called Amador, and it's called I'm Not Sick, I Don't Need Help. And a lot of the families that I've taught in NAMI have this situation because their family member doesn't want help, doesn't want the med. And Xavier Amador, and you can look at him on YouTube, there's him, he gives the spiel. So basically, his way is to come with the person, iMessages, and then to just talk about the facts. So, not emotionally, but this is what I see going on for you. And the iMessages, that's all you can do. You can't force somebody into treatment. But in time, like, oh, I see that when you were doing therapy or when you were with your counselor and doing your regular appointments, you were passing classes. I see now you're getting F's in these classes, or you're not employed anymore. I see when you were taking your med, you enjoyed that job, and you were taking. So you're just sort of stating facts in their life that work better when they're taking care of their mental health. And it's a slow process, and there's no magic to it. But Amador, I think, is one author who really addresses it, and it's helpful.
I think too that, you can, as you were saying, just kind of sharing that, whether it's a friend or somebody else, that I really care about you. I really care about our friendship, and I get a lot out of our friendship or our relationship. But this is getting to a point where it's really impacting our relationship, and I really just want you to get some resources that are going to help you, because it's impacting how we're relating, and I don't want to lose our friendship, because I'm so worried about you that it's hard to keep all those good things there. So.
Okay, well, before we end, are there any last-minute questions? No? Captain K?
It's actually not a question. It's leading to what, the biggest thing that I was taught, because, my career right there, 30-plus years of what she does, is the mental illness is the biggest thing I see. A lot of people with mental illness don't have insight. If they can't see it, how do they know? I mean, that's the biggest thing. Yeah. That's not easy. I mean, I could tell you something 1,000 times. Tie this boat up. I don't know how to do it. What are you talking about? So if they can't see it, it's easy to say that, but really, it's not what it is. I mean, our middle son, took him, 3-4 years. He was a kid that was an honors student in high school. Was in the arts program here, and he never saw it. He got impacted.
And that's part of that frontal lobe, frontal cortex not working,
So
that they don't have insight.
I mean, how many times it's tough, that I will say. Yeah.
And I would like to say these amazing NAMI people on campus, thank you for putting this on. What a great job.
Our panel for coming. Thank you so much. And one last thing, I want to thank you all so much for coming. It means the world to us and me and them. And to reach out to anybody, and you can reach out to me. My name's Brogan again. But seriously, people are here for you, and spread the word. And let's combat the stigma.